So good morning, everyone, and thank you for joining us today. So this webinar will focus on our ClipQ approach. So how collaborative and intensive pragmatic qualitative research can support responsive innovation in public health and healthcare. And we're from ARC West, and ARC West is one of 15 ARCs across the country. And we're partnerships between universities and communities and healthcare system designed to integrate academic research into health and care practice. And over the past 10 years, our behavioural and qualitative science team at ARC West has been adopted the ClipQ approach to try and ensure our findings are timely and trustworthy to inform real-world impact. I'm Jeremy Hord. I'm a professor of social science and applied health research in the medical school at Bristol University, and I co-lead the behavioural and qualitative science team at ARC West. And today, joining me are my colleagues, Jo Keston.
Good morning, everyone. I'm a research fellow in ARC West and the Health Protection Research Unit in Behavioural Science and Evaluation.
And Ava Lawrence.
Hi, morning, everyone. I'm a research fellow in the medical school at University of Bristol.
And Mairead Murphy.
Hi, everyone. I'm the Associate Director of Evaluation and Insight at Health Innovation West of England, and I'm also an Honorary Research Fellow at the University of Bristol.
Thank you. So for this webinar, we'll discuss what the ClipQ approach is, why it matters, and we're going to use case studies to demonstrate how it works in practice. There's a Q&A button, so if you've got any questions during the webinar, please put your questions in there, and we'll do a Q&A at the end to answer some of your questions. The slides and the recording of the webinar will be available in a couple of weeks, and they'll be on our website. And if you've signed up to the webinar, you'll be emailed a link to that when it comes live as well. Okay, so let's just start with some context. So traditionally, qualitative methods have faced challenges in producing timely findings to inform decision-making, often taking months or years to produce findings. However, people working in public health and healthcare may require evidence sooner than that to guide their decision-making and to be more responsive to the changes that's happening in the real world in the healthcare system. During the COVID-19 pandemic, this was really accelerated when people really wanted findings in weeks rather than months to drive impactful real-world changes and responses to what was happening during the pandemic. So therefore, we needed a research method that's both rigorous and responsive to real-world challenges and ensure findings are produced that are responsive to inform decision-making. So how can we overcome the tensions between producing responsive findings while also making sure that our studies are rigorous and our findings are credible and trustworthy, even under this intense time pressure that happened during the pandemic? And we've been using the ClipQ approach for 10 years now, but it really came to its fore during the pandemic. So the aim of the webinar is to introduce our ClipQ approach. And the ClipQ approach integrates collaboration at every stage of the research process. So that's more ensuring that we've got the key players around the table. So that's including people with lived experience, policymakers, and end users of our findings. So they're all part of the research team. It's also important that it integrates intensive team-based approach to cycles of data collection and analysis, working as a team to collect the data and analyze the data at the same time. And also the approach is also pragmatic, being able to adjust to the needs of our partners. And we'll demonstrate this through a series of case studies so you can see how ClipQ works in practice. So these are the three case studies that we're going to be using today. So the first is the RAPSI project, which Mairead led on. And this happened at the very start of the pandemic. And it investigated how GP practices dealt with a very rapid implementation of remote consultations during that first lockdown. And we did repeat interviews with practice staff between May and July in 2020. The second study is our back to school study that Ava led on. And this also happened in the summer of 2020. And this is when the government were issuing a range of infection control guidance to schools ahead of schools opening that September. So we interviewed school students, their parents and carers and staff to investigate the attitude to these measures and see how acceptable and feasible these measures would be. And finally, we're going to be using an example from before the pandemic, and this is our low versus high dead space syringe study that Joe led on. Now, dead space is the bit in the syringe that holds blood after it's been used. And low dead space syringes hold less blood, so it can reduce the chances of spreading infections like HIV and hepatitis if the syringe is reused or shared. So we investigated the attitudes of people who inject drugs and those that work with them from switching from high space to low space syringes to inject drugs. So we talk more about these case studies as we're going along. So in terms of the structure of the webinar, we're going to be talking through the Klipke approach through each stage of developing and delivering a research project. So we'll start off with setting up the project and the very initial management of the project. So a project setup and management, it's really important to have the right people around the table. So it's really important to think about that at the very start and foster an equitable partnership and embedding collaboration across all stages of the research process. So involving people with lived experience, community organisation, practitioners, and decision makers to ensure diverse perspectives shape the project. These early meetings are really important to deepen contextual understanding. So make sure the research team are really familiar with the study context and the implications of the studies and the findings. It's also good at the start to make sure we're defining the key research questions so everyone agrees on what the project's core objectives are. Also at the start, it's also to think about what the potential obstacles may be. So it could be things like challenges with recruitment and just to develop strategies at the start that may overcome barriers. So thinking about multiple different recruitment strategies. Also at the start, we also like to think about the end of the project. So identify the key audiences and the best communication channels to maximize the impact and reach of the study. So who are you trying to talk to? Who are you trying to reach with your findings? And once we've sort of sat down and we've discussed all of these, we then document them. So we do something called a collaborative project framework. And this is the document that outlines the aims of the study, the roles, responsibility, expectations, and time commitments of people working on the study, and also our impact strategy. And this is really to keep the team aligned and accountable to what the study is trying to achieve and what everyone's roles are in the study. So for an example of this, I'll just hand over to Mairead, who will talk about our RAPSI project.
Thanks, Jeremy. So yes, I'm going to tell you a bit about the RAPSI study, and I'm going to focus solely on the setup and management phase. Because like Jeremy said, this is a really critical phase to get right in a collaborative and responsive research or evaluation project. The aim of the RAPSI study was to investigate how GP practices dealt with the rapid implementation of remote consulting, and that was during the first COVID-19 lockdown. It was a mixed method study, so it was qualitative with a parallel quantitative arm, but I'm only discussing the qualitative today. And this involved 87 interviews done in rounds of just over 20 per round, and with reporting back to our partners after each round. And that was over the period May to July 2020. So the slide here shows the timeline for the project set up, and you can see the dates running across the bottom, and you'll see it was extremely rapid. So the funding call came out on the 11th of March 2020. That was an unusual and memorable day for all of us because that was the day that COVID was declared a pandemic. So amid watching the news reports on this, we mobilised our co-applicants, agreed our research question and developed and submitted our proposal. And then as we were submitting it, the first lockdown was announced, schools were closed and non-COVID research was paused. We were then awarded the funding on the 31st of March, just 10 days after the call was announced. And within another 2 or 3 weeks, we had mobilised the team, completed the protocol and ethics, and had approval from the HRA, which is the Health Research Authority. So we were then able to hold our first interview on the 1st of May, and then very quickly put in place that governance that Jeremy was just talking about, the regular data collection and reporting procedures, so that we were able to deliver our first report on the 5th of June. And that was delivered to the primary care cell of the clinical commissioning group, whose job it was to support GP practices and to make sure that they were able to deliver services throughout the pandemic. So it was really important that we did this quickly, and we were very proud of how we were able to turn it round from funding announcement to reporting in less than 3 months, including those ethical approvals. But the important bit and the real learning from this is how that was enabled. And I've listed what I see as the key enablers along the bottom of the screen. So firstly, there were existing very established relationships between the researchers and the clinical commissioning group, or the CCG is the abbreviation you'll see there. That's the regional body that commissions and funds healthcare for the region. And the CCG in Bristol has a very effective research and development support team. So the ARC and the University of Bristol had worked with this team for many years. So the relationships were there, so they were able to support us very quickly, get the right co-applicants on our grant and get us embedded in that primary care cell where we really were going to have the impact. Bristol, North Somerset and South Gloucestershire also have a really strong and effective GP federation called OneCare, who knew the research team well. And these existing relationships in this environment meant we weren't operating alone. We were really pulling together to set up that organisational working. We also had established relationships with the funder, which was one of the reasons we were able to mobilise the funding so quickly, because that trust and commitment was already established. And of course, it's important to say there were COVID-19 accelerated approvals. So while we still had to go through the same ethics and governance as any other time, we were able to do it more quickly than other periods because the research ethic committees prioritised our applications. And the last thing to say is there was a very strong shared vision at that time and a motivated team. You'll remember that March to May 2020 was a period when everyone was committed to working together to make things happen. And all these factors combined meant we were able to get this set up really quickly. So that's how we set up the RAPSI study. And I'll hand back to Jeremy now to talk about the next process in ClipQ.
Thanks, Mairead. So next we'll move on to establishing the aims of the study. Now, to establish the aims of the study, we work closely with the partners that we've got around the table to determine the most pressing needs and set out a clear scope for the research. So this is focusing on the critical issues, so having quite a narrow focus for the study as well. So thinking about the research questions that are the most impactful and ensuring their relevance and value. We also adopt a targeted pragmatic approach. So keeping the focus on the key questions and that are actionable and have real world insights. It's really important when you're thinking about the research questions. It's also important to stay adaptable. So remain open to the shifting priorities, so especially during the pandemic when things were changing on a weekly and daily basis sometimes. So allowing the research to evolve rapidly with these changing conditions. And then it's also important when thinking about the project's impact at the start. So clarify the desired influence that you want from the project and the pathways for change. So ensuring that everyone in the team understands what success looks like and who are at a benefit. So who do we want to influence and how? And then I'll now hand over to Ava, who will talk about our back to school study.
Great, thanks, Jeremy. So as already mentioned kind of in the intro, the aim of this study was to look at the attitudes towards COVID-19 mitigation measures ahead of school campuses opening in September 2020. We used qualitative interviews with students, parents, carers and staff, and the hard deadline of schools reopening in September 2020 guided the aims of this project, because schools had very specific questions that needed to be answered in order to be able to reopen their campuses on that deadline. So this deadline obviously meant the project had to be very rapid. We had a really short window, a few months, to conduct the entire project and get the findings back to the schools. There was a need for evidence to inform decisions being made over that summer, both by policymakers and by individual schools. So responsiveness was also really crucial in this project because the situation was changing sometimes almost daily over those few months in terms of both government policy, but also within individual schools and how they were reacting to the changes. So the aims of the study were developed through working with a variety of different people and groups. This included public health leaders and using input from heads of school and community groups within COVID meetings. The study also was designed in collaboration with local education leaders, community groups, and ARC West's Young People's Advisory Group, which was a group that had already been set up. So we were able to really rapidly access them and get some really valuable feedback quite quickly. And similarly, we had existing connections with other researchers here at the university who could provide advice on the aims of the study and make sure they were really the right ones for the project. And ARC West's existing connections were really useful here, enabling us to access the expertise and make sure the aims were developed with rigour in a rapid time. Thanks.
So next we're going to be moving on to how we approach the recruitment and sampling of participants. So in order to have effective participant recruitment, it's really important to leverage local expertise. So partner with on-the-ground collaborators to co-design accessible and acceptable recruitment strategies and materials. And we do this by engaging with trusted community organisations. So groups that have trust with different communities to enable effective recruitment. It's also important to prioritise diverse voices, especially if you're doing things rapidly. So make sure you stop and pause and think about who you're actually recruiting as well. So we hold regular debrief sessions with our collaborators to ensure the inclusion of unrepresented perspectives and also identify which voices may be missing from our data as well. Also, we think about maximising the data value per participant. So by this, we mean focusing on getting rich, in-depth data from each participant, or something we call about information power. And this can then the need to reduce the sample size. So if you're getting really rich data per interview is really important. Also, it's important to plan for flexibility in recruitment as well. So as I said before, incorporating contingency recruitment plans in the protocol at the start is really important because this prevents delays and avoids the need to go back to the ethics committee for approval of protocol amendments. So making sure you have a range of different recruitment strategies at the very start is really important. And I now hand over to Jo, who will talk about our low versus high dead space syringe study.
Thank you, Jeremy. So this study exemplifies elements of CLIP-Q outside the context of the COVID-19 pandemic. Rather than time constraints, as we've heard about in the previous two case studies, the drive for responsiveness stemmed from the importance of meeting the needs of the participant population, in this case, people who inject drugs, which as a marginalised community can be underserved by research. In terms of background to the study, sharing and reusing injecting equipment is a risk factor for passing blood-borne viruses between people who inject drugs. And this risk is informed by the amount of virus and the quantity of blood in the syringe, which is determined by the residue or dead space between the bottom of the plunger and the sort of top of the needle once it's been fully pressed in. So there are two main types of injecting equipment, those where the needle is fixed and those where the needle can be detached. Standard injecting equipment with detachable needles contains around 10 times more dead space than equipment with fixed needles. So increasing the number of low dead space syringes in circulation could help to reduce the number of people with hepatitis C and HIV because they transfer less blood and viruses such as hepatitis C and HIV survive for less time in low dead space compared to high dead space equipment. Both NICE and the World Health Organization guidance recommend needle and syringe programs where people can access clean injecting equipment offer low dead space syringes. And at the time of this study, detachable low dead space syringes were available in a range of different sizes, but they were not yet widely distributed. So this study used one-to-one interviews to explore the views of people who inject drugs and professionals and volunteers who work with them on the acceptability of detachable low dead space syringes and whether an intervention is required to promote their use. We conducted this research in partnership with a local organisation called Bristol Drugs Project. It's a drug and alcohol service operating in Bristol, and they were really key in identifying this research as a priority, as they were considering introducing detachable low dead space syringes and wanted insights into the best way to implement them, the most acceptable way to implement them. Prior to conducting the interviews, I went through a process of familiarisation with the services offered by Bristol Drugs Project. I spent time in their needle and syringe programme to understand different injecting practices, the language used by people who inject drugs and staff, and the equipment that's offered. And this familiarisation process also involved attending a 2-day safer injecting training course and shadowing staff. And the purpose of these activities was to become really sensitised to the experience of people who inject drugs and staff, and to build our partnership with the drug service, the recruiting organisation. In addition to informing my understanding of the research context and informing our topic guide, being present at Bristol Drugs Project helped create a sense of familiarity between me and the service users, which was really important in terms of building trust with potential research participants. We worked really closely with Bristol Drugs Project during the research to develop our approach to data collection and recruiting participants, because we were very concerned that we wanted to enhance participation and remove any obstacles to that. So staff from Bristol Drugs Project facilitated interviews by providing information, written information, and discussing the project with clients. And the advantage of this approach is that Bristol Drugs Project have a rapport and trusting relationship with their clients. And this helped to signal to people that the study and I could be considered credible and trustworthy. In terms of data collection, I spent blocks of time in Bristol Drugs Project conducting interviews. And at the start of the project, we worked really closely with Bristol Drugs Project to identify the most appropriate way to recruit people. And we decided that we couldn't use the traditional approach of providing written information and then pre-arranging interviews, because this didn't fit with people's lifestyles and the challenges they experience around attending appointments. So instead, we used opportunistic interviewing, whereby once someone indicated an interest in participating, they could do an interview then and there if I was present. And this is a departure from the tradition of ethics committees wanting participants to have time to consider taking part. However, we felt this was a more ethical and responsive approach for the participants of this study. And it really highlights the value of working out what will work for particular participant groups. However, in busy periods, this approach sometimes resulted in me doing 4 or 5 interviews back to back. And although we had focused research questions, participants often valued the opportunity to be heard during the research process and to share details about other aspects of their lives, which included a lot of trauma. So the sort of drawback or things to consider around this is the impact on the researcher from doing several interviews in one go, and balancing this with the need to make the most of the opportunity to speak to people who may struggle to participate if they're required to make appointments to do the interviews. It was also really important to pause after each round of interviews and consider the data that we'd collected and the composition of the sample and who we might want to speak to next, for example, in relation to gender. So I'll hand back to Jeremy now. Thank you.
Thanks, Jo. So next we're going to focus on how we approach data collection and analysis with the ClipQ approach. So for effective data collection analysis, it's really important to let the focus research question lead the way. So by this, I mean keeping the data collection analysis tightly aligned to the focus research question. It's also really important to embrace collaborative, team-based, iterative analysis. So for this, we use a team-based approach. So the team continually refines insights through collaborative cycles. So this involves the team of researchers collecting the data and also analyzing the data together to speed up the process. So we do this by using a structured approach. So things like the framework approach. So this means that the team can work together on the same document to code the data, and this enables both deductive and inductive analysis. And then we foster insights through regular team debrief meetings. So the researchers get together and think about and discuss the data and the analysis. And this enhances team reflexivity and sharpens the data interpretation. So by discussing the data collection together, we can make rapid changes to topic guides, and we can also make changes to the coding of the data as well, discussing it as a team. Now, it's also important to think about balancing depth with efficiency as well. So while we're condensing and summarizing the data with actionable insights, we're also working to preserve the richness and the context of the data as well. And for example of this, I'll hand over back to Marie to talk about the RAPSI project.
Thanks, Jeremy. So yeah, I'm going to talk now about how we analysed and reported on RAPSI, hopefully in the process answering some of the questions appearing in the Q&A about how we managed to analyse 87 interviews. We used all the elements that Jeremy just discussed, combining inductive and deductive approaches with a team-based approach and guided by the research question. So I explained before that RAPSI was done in rounds, and we reported to the primary care cell 4 times between May and June 2020. And they were really keen to understand what problems and barriers general practice was facing, and particularly with regards to remote consultation, and also what good practice could be shared. So that was really our focus at all times. We started in round 1 with 22 interviews, and these were carried out by a team of 3. So in terms of workload, we took 6 to 8 practices each, and we conducted the interviews and then put these directly into a framework data capture sheet without transcribing, just by listening to the interviews, either immediately after the interview or sometimes even during the interview. And we then rapidly produced a report from this framework, and we took this report to the primary care cell, presented it, and answered their questions. The members of the cell would then have more questions, which informed the next round. So we fed that back to round 2 and again to round 3, and continually pivoting our framework and topic guides to support that primary care cell with information right through to round 4. And then we delivered a final round 5 report that included all the interviews, plus reflections of everything the primary care cell had done in that 4-month period. So like I say, this was quite rapid. The time frame was May to August, September 2020, really guided by the needs of that primary care cell. We also wanted to reflect more on the data and analyse it according to some established theories. So sometime in round 4, we had the interviews transcribed, and we analysed these again as our team of 3, more formally and in vivo. And this analysis was definitely sped up by the fact that we had done the framework analysis, so we all knew the data really well. But we did take some different lenses to it. So we looked at it through the lens of NPT, which we hadn't done for the primary care cell. And we published 3 highly cited papers. The first of these was published in the BJGP, and it's been cited more than 450 times. It's certainly the most cited paper about remote consultations in general practice during COVID. And I do think a large part of the reason for that is that it was the first. So the time frame for this was August to July 2021, and our very highly cited paper was published in February 2021. So the fact that we were able to operate rapidly what it really supported the primary care cell, which is what the drive for speed was, but it also really supported our research impact. Because we were the first to publish, it increased our citations. And I think it also made for more robust and tested findings because they were continually being essentially member checked by the primary care cell, who were also authors on our peer-reviewed papers. This was really an important learning for me. We often see speed and robustness as a trade-off, but in this case, the analysis method increased the robustness as well as the speed. So I will hand over to Eva now to give us a bit more of an in-depth example of this kind of responsive and iterative analysis.
Great, thank you. So yeah, just as mentioned earlier, the back to school study was highly responsive to the constantly changing situation. So data collection and analysis kind of had to adapt and be quite agile to respond to this situation. So I'll just talk a little bit about how we did the kind of iterative and team coding approach. We used an iterative approach to data collection and analysis. So we were constantly adapting the topic guides and the recruitment strategies after pretty much every interview, and kind of in response to what was happening in terms of policy and school thoughts around reopening. As we had such a short timeline for the project, analysis began immediately after the first interviews had been conducted. So like Mairead said, similarly, we were kind of working from notes and audio recordings before waiting for the full transcripts. And then as the lead researcher, I developed a framework in Excel, so using the framework analysis approach. So you can see an extract there, just to highlight kind of what it looked like. So this framework included a description of the themes and the sub-themes and how they related to each other, and a section for all of us to put our thoughts about the theme. So it's just making sure we were transparent with each other and we were all kind of working from the same framework and had an agreed understanding about what themes meant. So then the other researchers on the team analysed some of the interviews, and they added themes or sub-themes and obviously copied their data into the relevant cells on the framework. The framework also included space for comments, questions, and emerging thoughts. So we kind of had a separate tab on there for those, and those were discussed at our regular team meeting. So it was constantly evolving and being updated by the whole team. We prioritised themes and data that were most important and relevant for the key groups involved, so schools, families and policymakers, and obviously again focusing on the research questions and the key information that was needed for that September reopening of schools deadline. So again, similar to what Mairead said, although this collaborative coding did require the whole team to be working really quickly and having lots of meetings and talking to each other constantly, it did really help with kind of exchanging expertise and improving the rigor of the analysis overall. So yeah, I'll pass back to Jeremy now.
Thanks, Eva. So finally, we're focused on knowledge mobilisation and how we disseminate our findings for maximum impact. So first of all, it's really important to embrace co-production for meaningful impact. So co-creating the knowledge with the stakeholders to help identify key, useful, clear messages and be able to communicate the implications of the findings as well. And that's where the collaboration is really important there. We can say what the main findings are, but working out what the implications are, speaking to our stakeholders to actually really see what the implications are for the findings. It's also important to draft the findings with the end user in mind. So ensure insights are relevant, they're accessible, and they're engaging for your target audiences as well. And this is where your wider collaborative team is really important to help refine those messages. So it's important to identify influential stakeholders early as well. So I said at the start, thinking about who are your end users, who are your target people that you want to influence. So making sure that from the outset, you've got your knowledge mobilization strategy. Who do you need to be working with to help disseminate this knowledge and try and have maximum impact for your findings? And we do this sort of through a double-pronged approach, really. So the first is sort of prioritizing dissemination for real-world impact. So this is sort of rapid feedback loops. So as Mairead and Ava both said, providing timely updates to stakeholders to support responsive decision-making. And so it's identifying what would be the most useful way to do that. So we do that through rapid reports that Mairead just talked about in terms of the RAPSI study. And then also talking about discussing things in team meetings. You may want to do a webinar, you may produce a slide deck. So really using the internet to get things out. With the rapid reports, we also shared them on social media as well. So it could get to a wider audience really quite quickly. And then secondly is a more sort of traditional approach for a broader reach. So this is doing the journal articles. And so as Mairead said with RAPSI, we then use theories, the normalization process theory, to develop those journal articles. So it's not just producing the journal articles, we also made sure we had preprints before the article was actually published. And especially during COVID, when evidence was needed quite rapidly, those preprints could be really useful. And then we also share it through presentations at national meetings to try and get a broader reach. So try and get more long-term reach of the findings. So I'll hand over back to Ava, who will talk about our back to school study.
Great, thanks. Yeah, so I'll just outline kind of the various outputs that we had from the back to school study, which really illustrates this two-stage approach to mobilising the knowledge from the project. So the final data set for back to school, we had interviews with 17 secondary school pupils, 20 parents and 13 school staff. So firstly, we published 2 rapid reports. One was interim during the project and one was final at the end of the project. These were 4-page summaries with some qualitative quotes. I just put a little extract on the screen there. These rapid reports were sent to local authorities, schools and national policymakers with a kind of clear, open invitation for feedback. They were also shared with the Bristol City and North Somerset Council's multi-agency children's COVID-19 response groups. The interim report was actually featured as a highlight in a Public Health England Behavioural Science Cell literature report. We also made use of ArcWest support and systems to publish news stories on the website and a blog and disseminate by social media. So it was really useful to have those colleagues able to quickly get the content out there. In terms of academic publications, we published the final study in BMJ Pediatrics, and we also published this as a preprint to facilitate rapid dissemination. Preprints really came into their own during COVID so that we could get the results up there as soon as they were ready to be published. Given the relevance of the project's findings to government policy, the preprint was actually disseminated to SPI-B, which, if you remember, was the behavioural science subgroup in the UK government's SAGE group, the Advisory Group for Emergencies. And findings from the project were also presented to the Department for Education and submitted to 2 parliamentary inquiries into the impact of COVID on education. So quite a wide range of outputs there going to different audiences. And again, just to emphasise that the existing connections from the team were really useful in the rapid dissemination and making sure the findings got to the right people. So having a contact or a name to get hold of in particular organisations was really helpful. I'll now pass on to Jo to talk a bit about how they did their dissemination.
Thanks, Ava. So as I said earlier, the Low Dead Space project began with interviews with people who inject drugs and staff to understand the acceptability and barriers to using detachable low dead space syringes. So Jeremy talked about the importance of working closely with our research partners. So in this project, we worked really closely with Bristol Drugs Project during the analysis to help us produce our academic outputs. And crucially, the findings of the study were then used by Bristol Drugs Project to introduce these syringes. From this study, we published 2 papers, one co-written with people with lived experience of injecting drugs. And the findings also contributed to the NICE consultation on needle and syringe programmes. We then wanted to really build on our research outputs and maximise the rollout of the equipment. So we decided to hold an event with key audiences and decision makers to think about how best to mobilise the findings. And this event was attended by a range of different stakeholders, including Bristol Drugs Project clients and staff, other service provider staff, local authorities and commissioners, public health experts and injecting equipment suppliers. From this event, we decided to create and distribute materials aimed at raising awareness of low dead space syringes and other harm reduction messages amongst service users, staff and volunteers in needle and syringe programmes, and also commissioners. So to help make this happen, Deborah Hussey, a Bristol Drugs Project assertive engagement worker, was seconded to ARC West for 3 days a week for 8 months, funded by the University of Bristol's ESRC Impact Acceleration account. Deb and I worked really closely together, visiting drug and alcohol services across England, Wales and Scotland to identify local issues and needs of the services and their populations, and how they might be able to use our research findings. And this helped us develop a set of preliminary key messages alongside our communications manager, Zoe. It also gave us a clearer picture of the type of materials that would be suitable and usable for needle and syringe programs to share with their service users to make sure that our findings, which were developed in the Southwest, could be applicable to other geographical areas. We then commissioned a designer, Michael Linnell, to bring the materials to life, and we did this by working with 5 Bristol Drugs Project clients who we met on 3 occasions. And from these meetings, we co-produced 7 posters, one of which is on the slide, a booklet and a series of short animations. Placing people who inject drugs at the centre of this process was essential to ensuring that our materials were appropriate, engaging, and did not stigmatise the intended audience. Rather than being done to them, the people we worked with talked about feeling fully involved in the entire process, and that having their voice heard and valued was a validating experience. And one of our co-designers continues to be involved in patient and public involvement activities in the ARC today. The co-design process required a really pragmatic and flexible approach to ensure our materials met the end user's needs. And without working with people with lived and living experience, the materials would have been very different and likely far less effective at communicating and engaging with the audience. For example, they may have contained depictions of cartoon characters, body imagery and humour, all of which were identified through this co-design process as having the potential to stigmatise and result in a negative response. So in terms of the difference the materials have made, they received really positive feedback, and in the 3 months since their launch, there were around 3,000 views of the website which hosted them and 5,000 views on Facebook, suggesting widespread reach. And the posters were also displayed in a safe consumption or safer injecting facility in Scotland. And for policymakers, a policy briefing was launched at an international webinar. I'll now hand back to Jeremy. Thank you.
Thanks, Jo. So just to sort of think about some of the key considerations when using the ClipQ approach. Now, the main one is ensuring adequate resources. So resources are key for supporting meaningful stakeholder involvement, ensuring community members are paid for their time, and also to fund this team-based approach to data collection and analysis when you've got more than one researcher collecting the data and also working the data to analyze it. So more funding needs to be there to allow for a team to work on a project as well. Also, it's really important to empower equal partnerships as well. So fostering that the collaboration with all members as active and equal partners alongside the researchers is really important, because their input is vital throughout the whole research process as well. Another consideration is doing analytic rigor through this team-based approach. So collaborative team-based working can boost analytic rigor from looking at the data from multiple perspectives, and allowing collective data interpretation is really, really key. And to be able to do that, you've got to cultivate a supportive, flexible team. So if you're going to do team-based research, you've got to have a supportive team, which is grounded in openness and in trust and flexibility, and having a non-hierarchical ethos with everyone looking at each other's data and looking at everyone else's coding as well. So trust is really, really key to be able to do that. And finally, thinking about how we balance academic standards with real-world urgency. So this is navigating the tension between maintaining rigorous academic standards and meeting real-world demands. And this can be doing things like Mairead said, like during the COVID projects, we directly coded from the audio. These days, if you do an interview via Teams, the audio is transcribed. The transcription is not perfect, but it does mean you can use that to do some rapid analysis to start off with, rather than waiting to send away an audio and wait for a transcription to be sent back. So technology has helped us do analysis quicker. So finally, let's think about the key points that we've talked about in terms of the ClipQ process and what are the priorities for ClipQ. So collaboration is key. So collaboration across every stage. So from the project design, the data collection, and the analysis and dissemination as well. It's really important to collaborate with key partners to maximize the relevance and impact of the study. So to do that, co-production is really important, particularly co-producing with people with lived experience. So people who bring lived experience can enhance the authenticity and the resonance of findings, making sure that they have real impact and they are relevant to key audiences. Also, intensiveness is really important for ClipQ as well. So this team-based approach to enable peer quality control when collecting data and analyzing data. And by doing this together, and this team reflexivity can speed up things and produce timely and relevant findings as well. Being pragmatic is another priority as well. So having a focused, pragmatic research design. So engaging collaborators to refine key research questions at the start, and then implementing a pragmatic, flexible design to respond to the evolving needs of the research project as you're going along as well. And then finally is our two-stage dissemination strategy as well. So for immediate impact, you may want to focus on the urgent needs and targeting the critical issues in rapid reports for key stakeholders. And then more long-term influence, so more traditional academic publications for broader, more long-term impact of your findings. So you can read more about the ClipQ approach in our paper, and in the chat, there's a link to our webpage and our paper as well. I'd like to thank you for your time and engagement, and we now welcome any questions or insights or reflections on the ClipQ approach. So if you add your questions to the Q&A box, then we can then answer it. I'll just stop sharing the slides. Okay, Mairead, are there any questions to respond to?
There's a lot of great questions coming in thick and fast. I mean, there's a lot of questions here on the speed of working. So did this impact on researchers? Is it suitable for all types of research, particularly where there's vulnerable populations or sensitive questions? Is that sustainable? How much of that was due to COVID? So maybe I'll pick up on that one and then you can add anything, Jeremy. But there's also questions about technicalities of the framework. So how was that developed? What level of experience of researchers is needed? Could this be done by any researchers or NHS teams, and on disadvantages of the approach? But on the speed of working, I mean, I think that question popped up, Jeremy, just as you were saying, this needs to be properly resourced. So it really links back to what you said about team-based working and resourcing this properly. If your starting point is the need, so for the RAPSI, our starting point effectively was the need of the primary care cell, and that need includes a time element, then you resource your team in order to meet that need. Now, yes, some of that was definitely due to that strong sense of shared vision during COVID. It often takes time to build that shared vision of why you're doing something. And for us in RAPSI, that was instant. But I think you can work in a similar kind of way outside of a COVID environment, like, you know, like some of the other presentations showed there. I think we did probably work in a more focused and intense way, but not necessarily to great detriment to ourselves. Not necessarily evenings and weekends didn't require that kind of work. I mean, to me, the key for that speed was the link into the primary care cell, and the reason we were doing it was to provide information to that. I don't know if anyone's got anything to add to that.
Yeah, no, I totally agree. And COVID was strange times, and it was where we needed findings, in weeks rather than months. That's not necessarily needed outside of a pandemic situation. So I like to think of ClipQ as responsive rather than rapid, that it's making sure that you're working with your good collaborators, with your partners to know what the key research questions are, rather than it would be nice to know, rather than what do we really need to know. And then making sure that you've got channels to actually disseminate that quickly as well. And the team-based approach does require resources. That we are lucky within ARC West, we have quite a large team of qualitative researchers, that if there is a demand on one project, we can pull people off another project for a time to work on that project and support each other as well. So it's having that supportive environment that's really, really important. But it is relevant outside of a pandemic situation because it is about being responsive rather than necessarily rapid. But during the COVID pandemic, things did need to be rapid. And especially with Ava and a back to school study, we had to get findings out by that September because schools were reopening in September. So we had a very hard deadline to get the information out.
Some of the other questions here are perhaps about the technicalities. So how is that initial framework developed? And a slight other aspect about co-production. How does co-production link with doing things rapidly? I mean, I guess that sort of links with what you've said, Jeremy. It's responsive rather than rapid. But maybe I don't know if Ava's presentation has already answered the framework questions, but there are some questions about how do you actually develop that initial framework and code into it.
Yeah, I have responded on the Q&A on that, but yeah, it was a combination of having some initial framework already set up based on the research questions and what we knew that we needed to find out to inform the schools and the policymakers and everything. And then it was also iterative, so it was a bit of both kind of developed as it went along. But yeah, we certainly started with an initial framework based on the research questions. Yeah.
Brilliant.
And I see there's a question around, co-production takes time, and how does that fit with ClipQ? I totally agree. Co-production is all about getting to know each other, and it's about trust, and it's about building that sort of equitable relationship with people. And that's why outside of a pandemic situation, it is about being responsive rather than rapid. As Mairead said, in terms of like the RAPSI project, we already had some established links. And the same with the back to school as well. We already had established links. We already had that working relationship that we built on to do very rapid work. But as Joe talked about with the syringe study, there was time taken with that study to build those links and to actually gain the trust of Bristol Drug Projects and people who are injecting drugs. And Joe, I don't know if you want to comment on that, that you did take a lot of time, time at the start of the project to develop those relationships, didn't you?
Yes, so I think co-production often is a timely process and it can't be rushed, but it's crucial to have those relationships or start building those relationships right from the start, so you have the right people around the table, as Jeremy said earlier. So it's not something that you're trying to do right at the end, trying to find people to work with.
I think we can probably pick off the questions actually quite quickly because I think a lot of them have been answered. Any tips for speeding up the submission publication process?
Well, that's where preprints are really important. So when you're submitting your paper to a journal, also doing a preprint and then sharing that on social media as well. And preprints really came into the all during the pandemic, but people still use preprints now.
Yeah.
especially if you know there's a policy document being written and it may take 6 months or something to get the paper published. Preprints are really key for that.
I think there was also a related question on preprints around whether funders have ever had a problem with them in terms of release, or not just preprints, but releasing findings before official publication. Don't know. I've never had a problem with that, but
No, but it's making sure you make sure your funder's requirements as well. So you may want to send a draft of the paper to your funder and say, we're doing this as a preprint, just so they're aware of it.
thanks.
Yeah. I think that's a really interesting question by Neva Edmond there. What are the disadvantages to the process compared to traditional qualitative research processes? I mean, for me, it links back to maybe some of Alison Gregory's points about particular populations, perhaps needing a little bit more of that traditional time to reflect. I don't know, does anyone have any other disadvantages?
No, definitely, and this approach may not be eligible for every study, but in those studies where you do need to be quite responsive, where there is a policy change or you are trying to influence real world impact in a very limited period, then it is an approach to take. But with some participants, this may not be appropriate as well.
Yeah. Yeah, I'd also agree and say that obviously this is applied research, so it's not as inductive as many qualitative approaches. So obviously it's focused on a particular research question and quite, but for a specific purpose, being applied research. So yeah.
And that does then influence the coding frame as well. When you've had those initial discussions about what are the key things people are interested in, but not just doing coding inductively, also allowing for inductive things to come out as well. But if there are key facilitators and barriers that people are interested in, that can help guide the coding framework as well.
Yeah. We've got a few minutes left. There's a specific question there on the dead space study about your amazing outputs, Joe, and whether that money and time was written into the funding, how you found the designer, how you went about producing those outputs.
Yes, great, thank you. We applied for funding after the original project from the ESRC to support the impact knowledge mobilization type work, and that's really the benefit again of working within the ARC, that we have that flexibility to be able to extend projects on beyond that initial data collection and write-up phase to really focus on the impact and knowledge mobilization. The designer we came to, I think, through one of our partners, and perhaps you can email me afterwards for more details about how expensive it was. But yeah, thanks for your interest.
And there's a question here talking about the real approach for rapid evaluation as well. And there are lots of similarities with the ClipQ approach. We're just trying to promote here how we work together and how we do it. There are lots of different rapid approaches to qualitative methods that all share very similar ways of working as well. We're just highlighting how we work and how this has actually benefited us working as a team. But the core of it is that team working. So making sure you've got a supportive team is really, really important for that. Any chance for one last one before we wrap up?
Probably an interesting one there is, how do you keep the focus of the analysis beyond identifying barriers and facilitators when the incentive is for quick practical results?
I think that's around working with your partners. What do your partners want to know? And barriers and facilitators can be a bit of a catch-all, but there may be key things that your partners are really interested in that can really help guide your topic guides and the analysis as well.
Yeah, I would agree. That's certainly it was my experience.
And that might start as your focus for your rapid report, which meets the immediate information needs from your stakeholders. But when you then do that second round of going back through your data for your academic publication, then I think you can look in more depth at other issues beyond that.
Okay, thank you, everyone. That's been really valuable. And thanks for all your questions, and thanks for spending time with us today. There will be a recording of the webinar on our website, and we will email everyone that signed up to the webinar. So you will get the recording and the slides in a couple of weeks. But thank you for your time today.